Understanding why people engage in certain health behaviors and how to effectively influence these behaviors remains one of the most important challenges in public health. The theory of reasoned action, or TRA, the theory of planned behavior, TPB, and the integrated behavioral model, IBM, represent three of the most influential and empirically supported frameworks for understanding health behavior determinants and developing effective interventions. This comprehensive teaching script provides an in-depth examination of these theories, their development, core constructs, measurement approaches, and practical applications. It's designed for health education professionals, researchers, and practitioners who are seeking to utilize these frameworks in their work. The theory of reasoned action was developed by Martin Fishbein in the late 1960s and further refined with Isaac Adzen in the 1970s. Its development responded to a fundamental problem in social psychology, the observed disconnect between attitudes and behaviors. Before TRA, researchers consistently found weak correlations between general attitudes and specific behaviors, which led some theorists to question the utility of attitude as a construct in behavioral prediction. Fishbein made a crucial distinction between attitude toward an object, for example, attitude toward cancer, and attitude toward a behavior with respect to that object, for example, attitude toward mammography screening. This distinction proved pivotal, since attitude toward the specific behavior was found to be a much better predictor of that behavior than attitude toward the general object at which the behavior was directed. The TRA was grounded in an expectancy value conceptualization with deep roots in psychology, drawing on learning theories like Rotter in 1954, attitude theories such as Rosenberg in 1956, and decision-making theories like Edwards in 1954. By the mid-1980s, Adzen recognized a limitation in TRA. It worked best for behaviors under complete volitional control, but was less effective for behaviors constrained by factors beyond personal choice. To address this limitation, Adzen added the construct of perceived behavioral control to TRA, creating the theory of planned behavior in 1991. This addition acknowledged that behavioral performance is determined jointly by motivation or intention and ability or behavioral control. The integrated behavioral model emerged from two parallel developments: a National Institute of Mental Health or NIMH workshop in the early 1990s brought together primary architects of several behavioral theories to develop an integrated theoretical framework. At the same time, Kasperzik, Montano, and Fishbein conducted a longitudinal study of HIV prevention behaviors, developing an integrated model that aligned with the NIMH workshop recommendations. By the early 2000s, Fishbein and colleagues had further expanded TRA and TPB, incorporating components from other major behavioral theories. The 2002 Institute of Medicine report, Speaking of Health, recommended this integrated model for health behavior change communication strategies. The TRA proposes two direct determinants of behavioral intention. First, attitude toward the behavior. That's the individual's overall evaluation of performing the behavior. This is determined by behavioral beliefs, which are beliefs about behavioral outcomes, and these are weighted by outcome evaluations or assessments of those outcomes. Second, subjective norm. That's the individual's perception of social pressure to perform or not perform the behavior. This is determined by normative beliefs or beliefs about others' expectations, and weighted by motivation to comply with those reference. In TRA, behavioral intention is viewed as the most proximal determinant of behavior. The theory assumes that behavior is primarily under volitional control. TPB maintains all TRA constructs while adding perceived behavioral control. This is the individual's perception of the ease or difficulty of performing the behavior. It's determined by control beliefs, which are beliefs about facilitating or constraining conditions, and weighted by perceived power or the impact of each condition. Perceived control is hypothesized to influence behavior both indirectly, through intention, and directly, especially when it accurately reflects actual control. The IBM retains all TPB constructs while expanding the model in several important ways. It adds additional determinants of behavior beyond intention, including knowledge and skills to perform the behavior, environmental constraints, salience of the behavior, and habit. The attitude construct is expanded to include experiential attitude or affect, meaning the emotional response to performing the behavior, and instrumental attitude, which is the cognitive evaluation of outcomes of performing the behavior. Normative influence is also expanded. Injunctive norm refers to perceptions about what others think one should do, similar to subjective norm in TRA and TPB, while descriptive norm refers to perceptions about what others actually do. Personal agency is conceptualized as a dual construct: perceived control, which is the perceived amount of control over behavioral performance, and self-efficacy, or confidence in the ability to perform the behavior despite challenges. Precise, valid measurement is crucial for applying these theories effectively. Key principles include that both TRA and TPB typically use 5-point or 7-point scales. Behavioral beliefs are measured on bipolar unlikely, likely, or disagree-agree scales from -3 to +3. Outcome evaluations are measured on bipolar good-bad scales, also from -3 to +3. Normative beliefs are measured on bipolar scales, -3 to +3 as well. Motivation to comply is measured on unipolar scales, from 1 to 7. Control beliefs are measured on bipolar likelihood scales, -3 to +3, and perceived power is measured on bipolar easy-difficult scales, -3 to +3. Both direct and indirect measures are important. Direct measures might be single or just a few items that directly assess the construct. For example, attitude is assessed with semantic differential scales like good-bad or pleasant-unpleasant. Subjective norm could be measured by items like most people important to me think I should, and perceived control with items like under my control, not under my control. Indirect measures are computed from underlying beliefs. Attitude equals the sum of behavioral belief times outcome evaluation. Subjective norm equals the sum of normative belief times motivation to comply, and perceived control equals the sum of control, belief times perceived power. Direct measures typically have stronger associations with intentions and behaviors, while indirect measures provide specific targets for intervention development. A critical aspect of measurement is ensuring high correspondence between measures of attitude, norm, perceived control, intention, and behavior in terms of action. For example, go get, target, for example, a mammogram, context, like at the breast screening center, and time, for example, in the next 12 months. Low correspondence between measures on any of these factors will result in low correlations between variables. A fundamental step in applying these theories is conducting formative elicitation research with the target population. This qualitative research phase identifies salient behavioral outcomes, normative reference, and environmental facilitators or barriers specific to the behavior and population. It ensures measures are empirically grounded rather than based on researchers' assumptions, and provides culturally appropriate content for questionnaire development. The recommended process includes conducting open-ended interviews with 15 to 20 members of the target population, ideally half who perform the behavior and half who do not. Questions should cover positive and negative feelings about performing the behavior, positive and negative attributes or outcomes of performing the behavior, individuals or groups who influence the decision, and situational or environmental factors that facilitate or hinder the behavior. Content analyzing responses helps identify relevant beliefs, reference, and facilitators or barriers. These findings are then used to develop questionnaire items that capture the language and concerns of the population. This elicitation process is what makes these theories applicable across cultures, despite criticisms that they represent a Western perspective. The theories provide a universal structure, while elicitation ensures culturally specific content. These theories have substantial empirical support. Hundreds of studies have applied the theory of reasoned action and the theory of planned behavior across really diverse behaviors and populations. Meta-analyses have confirmed that the theories explain a large proportion of variance in behavioral intention and predict numerous health behaviors. Intervention studies also demonstrate that changing theory constructs leads to subsequent behavior change. Applying these theories effectively follows a systematic process. First, there's behavior specification. It's important to clearly define the target behavior in terms of action, target, context, and time frame. For example, using condoms, action, during every instance of sexual intercourse, context, with all partners, target, over the next 3 months, time. Second, elicitation research. Here, you conduct qualitative research with the target population to identify salient behavioral outcomes, important reference, and facilitating or constraining conditions. Third, questionnaire development. This means developing and pilot testing measures of direct theoretical constructs, indirect measures based on elicited beliefs, behavioral intention, and when possible, actual behavior. Fourth, model testing. You analyze data to confirm that your measures explain behavioral intention, determine which constructs are most important for the specific behavior and population, and identify the specific beliefs most strongly associated with intention. Fifth, intervention design. You develop interventions that target the most important constructs, focus on modifiable beliefs with room for change, and consider the full pattern of relationships between constructs. And finally, evaluation. You assess whether the intervention changed targeted beliefs, whether those changes led to changes in theoretical constructs, and whether changes in constructs led to changes in intention and behavior. An exemplary application of the integrated behavioral model was conducted to promote condom use among rural Zimbabweans. In the formative phase, the behavior was defined as using condoms all the time with steady partners in the next 3 months. Elicitation interviews were conducted with about 8 randomly selected individuals aged 18 to 30 in each of 32 rural villages, half male and half female. Through content analysis, researchers identified common feelings, behavioral outcomes, normative reference, and barriers or facilitators related to condom use with steady partners. Next, questionnaire development. Measures were created based on elicitation findings, using verbatim comments whenever possible. These were pilot tested in 2 rural villages representing the 2 main ethnic groups, Shona and Ndebele. The final instrument was translated into local languages, Shona and Ndebele, with back translation to make sure the meaning was preserved. The survey was then administered to about 185 residents in each of 30 rural sites, totaling 5,546 participants. For analysis and intervention planning, model confirmation verified that attitude, perceived norm, self-efficacy, and perceived control explained intention to use condoms with a correlation of 0.69. Belief analysis identified specific beliefs most strongly correlated with intention. Key behavioral beliefs included concerns that condom use would make the partner angry, show lack of respect, show lack of trust, or suggest infidelity. The key normative belief was the perception of a partner's approval being most influential. Key efficacy beliefs included concerns about the ability to use condoms when partners get carried away, when alcohol is involved, when using another birth control method, or when the partner doesn't want to use condoms. For target selection, researchers selected beliefs that were strongly correlated with intention, showed substantial room for change, meaning there were large differences between intenders and non-intenders, and could feasibly be changed through persuasive communication. Finally, intervention development. The findings guided development of a community popular opinion leader intervention based on diffusion of innovations theory. Opinion leaders were identified and trained to understand the integrated behavioral model conceptualization. Persuasive messaging focused on the specific beliefs identified in the research. Role-playing sessions helped opinion leaders develop and practice persuasive arguments. Structured conversations with community members addressed reinforcing positive behavioral beliefs, countering negative beliefs, reinforcing normative support, and building confidence to overcome barriers. So recent developments in TRA, TPB, and IBM research include, some pretty exciting integrations with digital technologies. Health behavior theories are, increasingly being applied to digital health interventions. For example, mobile health applications are now using tailored messaging based on specific beliefs. And then, there are just-in-time adaptive interventions, which deliver theory-based content right at those crucial decision points. Oh, and let's not forget about social media campaigns, which are leveraging descriptive norms through social networks. All right, let's talk about some of the strengths first. There's a clear conceptual framework here, with well-defined constructs and relationships. It offers solid empirical guidance by identifying specific targets for intervention. The methodological specificity is a real plus, too, with detailed measurement protocols. Another thing, the framework actually applies across cultures when it's properly implemented, so that's pretty impressive. And it's got strong predictive validity, meaning it explains a substantial amount of variance in both intention and behavior. Now let's take a look at the limitations. There's what we call the intention-behavior gap. Intentions don't always translate to actual behavior. The focus is mostly on rational decision-making, which can underestimate emotional and automatic processes. Sometimes contextual factors, like environmental determinants, might be underrepresented. Also, to apply this properly, you need substantial formative research, which can be a real resource requirement. And finally, translating these findings into effective interventions actually requires additional expertise, which can be a bit of a challenge. So, moving on to best practices for implementation. For researchers, it's important to conduct thorough elicitation research with the target population. You want to make sure there's high correspondence between your measures. It's also a good idea to use both direct and indirect measures of constructs. Whenever possible, employ prospective designs. Don't forget to analyze belief patterns within important subgroups, and definitely test mediational hypotheses to confirm the theoretical mechanisms at play. For practitioners, the first step is to use formative research to really understand the target population's perspective. Identify which constructs are most influential for the specific behavior you're targeting. You'll want to focus on modifiable beliefs that still have substantial room for change. Develop persuasive messages that address those key beliefs, and make sure to test those messages with members of your target population. Lastly, be sure to evaluate your interventions at multiple levels: beliefs, constructs, intentions, and behaviors. The theory of reasoned action, theory of planned behavior, and integrated behavioral model really do provide powerful frameworks for understanding the determinants of health behavior and for developing effective interventions. Their strength lies in providing clear conceptual frameworks while still allowing for empirically derived, culturally specific content. By following a systematic process, elicitation, measurement, analysis, and targeted intervention, health professionals can apply these theories effectively to address a wide range of health behaviors across different populations and settings. And as these theories continue to evolve, incorporating new constructs, methods, and technologies, they'll remain relevant to the health challenges we face today. The fundamental insight remains: to change behavior, we must first understand the specific beliefs that drive it in our target population. These theories provide the roadmap for that understanding and for translating it into effective health promotion efforts. So let's think about a few discussion questions. How might the relative importance of attitude, perceived norm, and personal agency differ across various health behaviors? What factors might influence these differences? What are the advantages and challenges of conducting elicitation research before developing theory-based measures? How might you address these challenges in resource-limited settings? Consider a health behavior change intervention you're familiar with. How might it be strengthened by applying the TRA, TPB, or IBM framework? How do cultural factors influence the application of these theories? What adaptations might be necessary when working with different cultural groups? And finally, how can these theories be effectively integrated with other approaches to behavior change, like environmental interventions or policy changes?